So in this video, I will be explaining in detail about evidence-based practice. Actually, few postgraduate students asked me about this particular topic. So this is the reason why I thought of doing some research topics. So by the end of this video, you will be able to understand what is the introduction and definition of evidence-based practice, as well as evidence-based physical therapy practice, aims and objectives of evidence-based practice, need components, different components of evidence-based practice, and different steps in evidence-based practice system, and evidence-based practice lighting system, and what are the different paradigm shifts, and what are the different barriers for evidence-based practice, and advantages and disadvantages of evidence-based practice, and what are the research or current evidence for evidence-based practice, and what is the conclusion. So coming to the introduction, one of the most important things for any healthcare or fitness professional to understand is that it is our professional duty to our clients to be sure we are staying current and following the evidence as our professions continue to grow. That is what many people believe is evidence-based practice. I believe this is one of the most important qualities you need to master to truly become an expert in our fields. We should always be learning and staying on the top of the latest research while keeping an open mind and growth mindset. Continuing to follow outdated concepts that have been proven to be ineffective or disadvantageous is a disservice to our clients and ultimately our profession. However, it is very common for students and new graduates to take this concept too far. This is not a criticism, just a statement that without clinical experience, it is often difficult to follow evidence-based practice as best as possible. So, paralysis by a lack of evidence. Here is one thing that I wish people understood. A lack of evidence does not mean a lack of efficacy. Research is hard and we are humans. And it is difficult to have a quality randomized controlled trials with adequate methodology to determine exactly what to do all times. It is the expert people that I know that grasp this concept the best. So it is more common for the inexperienced to have what I call paralysis by a lack of evidence. They often state that without clear evidence, we should not be performing certain interventions. This couldn't be further from the truth in my mind. So, as physios, we often hear the term evidence-based practice. What does it actually mean? Evidence-based practice is a process used to review, analyze, and translate the latest scientific evidences. The goal is to quickly incorporate into evidences into clinical practice. So, evidence-based practice is actually the cornerstone for your clinical practice. Integrating this evidence-based practice into your physiotherapy practice improves the quality of care and the patient outcomes. So coming to the definitions for evidence-based practice as well as evidence-based physiotherapy practice. So the evidence-based practice is the integration of best research evidence with clinical expertise and patient values, which when applied by practitioners will ultimately lead to improved patient outcome. So this was put forward by Sackett et al. In 1996 in the British Medical Journal. So this was actually the paper or the origin for this evidence-based practice or evidence-based medicine. So coming to the definition for evidence-based physiotherapy practice, it is an open and thoughtful clinical decision making about the physical therapy management of a patient or client that integrates the best available evidence with clinical judgment and the patient or client's preferences and values, and that further considers the large social context in which physical therapy services are provided to optimize the patient or client outcomes and quality of life. This was put forward by John and Bartlett. And coming to the aim of evidence-based practice. So the aims for evidence-based practice is to provide high quality and most efficient physiotherapy care possible, and to advance the quality of care provided by the physios, to increase the satisfaction among the patients, to focus on physiotherapy practice away from habits and tradition to evidence and research, to get better patient outcomes, to keep the practice current and relevant, to increase confidence in decision making, and what are the different objectives and purposes for evidence-based practice. So it seeks to replace the practice as usual with the practice guided by the rigorous outcomes oriented research, ideally the randomized controlled trials. It also seeks to make practice a less subjective enterprise and to rise it to a higher level of accountability. It reduces the variations in physiotherapy care and assists with efficient and effective decision making. And it also provides practice to the physios, evidence-based data to deliver effective care. And what are the need for evidence-based practice? So it includes for making sure that each client gets the best possible services and to update the knowledge that is essential for lifelong learning and to provide the clinical judgment to improve the care provided and for to provide the framework for understanding the evidence-based process. And what are the different components for evidence-based practice? So in the original model, there are three fundamental components of evidence-based practice. In this diagram, you can able to see these are the two same diagrams in different shapes. So in this, you can able to see the best scientific evidence is one of the component. Patient values and care or expectations is the other component, and the clinical experience is the second component. So this is about the components of evidence-based practice. So this is the evidence. So evidence-based practice, in this, evidence is seen as a tip of an iceberg, and the patient values and clinical experiences was under the water. So this concept was outdated and it has been changed into a newer concept, which I will be explaining in detail in the upcoming slides. So this is one of the another concept. This includes four components that includes the clinical expertise, the research evidence, information from the practice context, patient values, circumstances, etc. So the components includes the best evidence, which is usually found in clinically relevant research that has been conducted using sound methodology. And second component include here clinical expertise that refers to the clinicians' cumulated education, practice, experience, and the clinical skills. Next is the patient values. Third component is your patient values and expectations, which are the unique preferences, concerns, and expectations each patient brings to a clinical encounter. So this is about the different components or domains of evidence-based practice. So it is this integration of these three components that defines a clinical decision evidence-based practice or evidence-based. When all three components of evidence-based practice are considered together, clinicians can make informed evidence-based decisions and provide high-quality services reflecting the interests, values, needs, and choices of individuals with any disorders. This integration can be effectively achieved by carrying out the 5 following steps of evidence-based practice. So these are the 5 steps for evidence-based practice, mainly the developing a well-built question, finding evidence-based resources to answer the question, evaluating the strength and applicability of the evidence, applying the evidence, and evaluating the evidence or steps. The first step is here formulating an answerable question. One of the fundamental skills required for evidence-based practice is asking of well-built questions. By formulating an answerable question, you can focus your efforts specifically on what matters. These questions are usually triggered by patient encounters, which generate questions about the diagnosis, therapy, prognosis, or etiology. So this is the first step And this particular question should be in a PICOT form or PICO format. So PICO means population, intervention, comparison, and outcomes. So this particular question, formulation of this particular question will be in a PICO format. And coming to the second step, that is finding the best available evidences, or this is, in other words, it is known as database or resource searching. So the second step is to find the relevant evidence. This step involves identifying the search terms which will be found in your carefully constructed question from step 1. Selecting the resources in which to perform your search, such as PubMed and Cochrane Library. Formulating an effective search strategy using a combination of mesh terms and limitations of the results. So in this step, you can use evidence-based practice resources such as your pre-applied resources or appraised resources or databases, or even you can use electronic textbooks and libraries or meta search engines. So in this, you can use your journal, different journals, or PubMed, similarly, which I mentioned here, PubMed, or Cochrane Library, or some other textbooks, like maybe different textbooks on the particular topic which you are going to research. So all this can be used. But the thing is that if you are taking some journals, means that will be having high validity or having more strength, research strength, comparing to your book evidences. The evidence will be higher according to the evidence-based practice. So try to take some journals rather than referring the books, because maybe the books will be little bit older comparing to the latest evidences. So the third step is appraising the evidence. So in another term, it is known as critical appraisal for the article or particular topic. So it is important to be skilled in critical appraisal so that you can further filter out studies that may seem interesting but are weak. Using a simple critical appraisal method that will answer these questions. You can use this critical appraisal method, so in which these following questions are answered. So the questions include: what questions did the study address, where the methods are valid or reliable, and what are the results of the study, and how do the results apply to your current practice. So these are the questions which has been seen in a critical appraisal method. Actually, there is one scale known as Pedro scale, PEDRO. Pedro scale can be used for critically appraising those particular articles which you are going to apply in your current practice or this particular technique. So this is the third step, that is critically appraising the article. So next step is fourth step, that is the implementing the evidence. Individual clinical decisions can then be made by combining the best available evidence with your clinical expertise and your patient values. These clinical decisions should be implemented into your practice, which can then be justified as evidence-based practice. So after critical appraisal, you will be coming to a conclusion that this particular topic or this particular condition has been effective in this particular technique has been effective in this particular condition, so that you can implement that particular treatment into your clinical practice. So that means it is evidence-based practice. So whatever your findings, you can just implement towards your patients. So next step, that is the fifth step, is evaluate the outcomes. The fifth or the final step in the process is to evaluate the effectiveness and efficacy of your decision in direct relation to your patient. Was the application of the new information effective? Should this new information continue to be applied to the practice? How could any of the 5 processes involved in clinical decision making process can be improved to the next time a question has been asked? So by this step, you can able to get an answer for all these questions. And these steps may be memorable if remembered as 5 A's. So first A is your ask, second acquire, third appraise, apply, and audit. So this is a 5A method for your steps in order to remember your steps in evidence-based practice. That is ask, acquire, appraise, apply, and audit. So these are the steps in evidence-based practice. First is ask. So in this we'll be asking a particular questions and acquire. So we will be acquiring or we will be collecting the different resources, different articles from different sources. Next, we will be critically appraise or critically appraising the evidence what we have collected, and will be sorting or filtering out. And next stage is analyzing. So after critical appraisal, we will be analyzing those articles to rate the strength of the evidences, and we will be coming to a conclusion, and that this particular technique has been useful for this particular condition. And in later, the fifth stage will be applying this particular technique to this particular condition. And at last, we will be assessing the patient for whether this technique has been shown some improvement to that particular patient or client. So this is the 5A's or 5 steps in the evidence-based practice: ask, acquire, appraise, analyze, apply, and audit or assess. So coming to the recent advances, in 2010, Melnick et al. Has proposed adding 2 more steps to this 5 steps process. So in total, we will be having updated steps, that is your 7 steps will be present in this evidence-based practice. So this first step and the last step has been added by this Melnick in the journal in 2010. So first step, that is step 0, that is cultivating a spirit of inquiry. So without this spirit of inquiry, the next steps of evidence-based practice are not likely to happen. And the step 1, asking the clinical questions in Picot format. Step 2, search for the best evidence. So step 3, critically appraising the evidence. Step 4, this integrating this evidence with clinical expertise and patient preferences and values. Step 5, evaluate the outcomes of practice decisions or change based on the evidence. And step 6 is disseminating this evidence-based practice results. So all these 7 steps has been put forward by Melnick et al. By adding or by creating a change in the normal 5-step evidence-based practice. So these 2 steps, step 0 and step 6, has been added by this particular person known as Melnick in 2010. So next is about evidence-based practice light system. When I'm trying to determine if an intervention I would like to do is appropriate based on evidence-based practice, I will consider what we call as the evidence-based practice light system. So it includes as your normal traffic light. So it includes your red light, yellow light, and green light. So red light indicates your stop. So if there is strong evidence by quality randomized controlled trials suggesting a safety concern or lack of efficacy, then you need to find an alternative approach that may be more advantageous. For example, if a particular technique has lack of research support, or in research support, in their research articles, they are mentioning that this particular technique is not effective, means or there is some safety concerns, means you should not use that particular technique for this particular condition. So that means they are coming under the red light system. And next system or next light is your yellow light. That means you can proceed your technique, but with caution, but with precaution, you need to use this particular technique. So when there is conflicting information or there aren't enough quality studies examining the effect that you are assessing, then you must proceed with caution. In this scenario, perhaps there are some low quality studies like a case study or publication without strong methodology that show efficacy, or maybe even some conflicting results in the literature without an overwhelming trend towards efficacy or lack of efficacy. So this means this particular technique has some evidences like your low quality evidence, that is your single case study or case series only, that doesn't means that have a strong methodological support. So in that case, maybe the author may be saying that this technique in their case study that this particular technique has been showing some improvement. So that doesn't means that it is in the higher evidence-based practice. So it doesn't have some strong methodology. So that is the reason why this particular type of scenarios comes under the yellow light signal of your evidence-based practice. That means you can use this technique in this particular conditions, but in a safety or precocious manner. So next light system is your green light system. That means go. So if there is strong evidence by quality randomized control trials suggesting efficacy, then you can comfortably use this approach with evidence-based justification. So this green light signal means that this particular topic or condition, this particular technique have enough evidence-based support and having a stronger methodological support. So that means that you can blindly use this particular technique to that particular condition. So this is all about the evidence-based practice light system. So next is about the paradigm shift. So paradigm shift is one of the terminologies frequently used in research, which may not be aware to few of the students. So actually, a paradigm shift means it is an important change that happens when the usual way of thinking about or doing something is replaced by a new and different ways. The evidence-based practice or the scientific research has brought few paradigm shifts in the field of physiotherapy and its practice. So one of the first paradigm shift are intervention process in the cerebral palsy. A widely used physical therapy intervention for children with cerebral palsy has been based on the Bobart neurodevelopmental treatment approach. This approach focused on the consideration of abnormal tone and postures during treatment, and interventions were not based on scientific research. The use of strengthening exercise was strongly discouraged by proponents of this approach because they believed that excessive effort would increase the co-contraction, spasticity, and associated reactions. The rationale for NDT approach was based on reflex-based or hierarchical view of motor control. It was felt that the patient's primary problem is producing a voluntary movement was antagonistic restraint, not agonistic muscle weakness. Emphasis was placed on interventions to prevent abnormal postures and excessive muscle co-contraction. Clinicians following this treatment approach avoid exercises with maximum efforts in people with spastic form of CP. So this was for in the Fowler EG et al. In 2001. So this has been shifted, or there have been some paradigm shift occurred in the recent researches. So the recent researchers have showed the improvement by using the strengthening exercises in individuals with cerebral palsy. So in the previous researchers, they had showed that this kind of strengthening exercise and particular exercises was not effective comparing to the NDT techniques. So later they had found that the benefits of strengthening exercises in individuals with cerebral palsy. The improvements in muscle performance have been demonstrated for people with cerebral palsy using isometric exercises, isotonic exercises, isokinetic exercises, and a combination of isotonic exercise and weight machines. So the findings refute the premise that the performance of exercises with maximum efforts will result in a large or detrimental increase in spasticity. So in the earlier studies, they had mentioned that if you are doing some strengthening exercise or exercises with maximum effect, they may try to increase the spasticity. But this studies or the recent shift in these articles, they had mentioned that maximum effects will not have some changes in the spasticity. So Damino et al. Suggests that the resisted exercise is an effective treatment strategy and as such should be considered as one of the components in the rehabilitation of children with cerebral palsy. Nowadays, different intervention techniques have shown high evidence like constraint-induced movement therapy, virtual reality, goal-directed treatment, hippotherapy, and hydrotherapy were effective in treatment rehabilitation of children with the cerebral palsy. So this is the two evidence support, that is the Damiano et al. And Novak et al. They had mentioned this maximum effect. So exercising with the maximum effect will not produce a increment in the increase or detrimental increase in the spasticity. So this is known as research spin. So sorry, this is known as a paradigm shift. And the bed rest for backache. So this is the second paradigm shift. Bed rest is a traditional treatment for back pain, yet only in recent years has the therapeutic benefit of this has been questioned. The most common management for back pain and sciatica is to prescribe analgesics and advise rest and to treat acute attacks with bed rest. This recommendation is based on orthopedic teaching, but there are increasing doubts and dissatisfaction with this kind of management. So Waddell et al. So they had mentioned like the bed rest is a useful technique. So later it has been shifted that the two key trials by Gilbert et al. And Deo et al. First showed the longer periods of bed rest have no advantages compared with shorter periods. So earlier researchers showed that they need the patients with back pain need enough amount or longer periods of bed rest. But later, in the paradigm shift, they had researchers had mentioned or researchers found that longer periods is not effective, or the longer periods of bed rest have no advantage over the shorter periods of bed rest. In 1994, clinical guidelines recommended that bed rest should be for shorter periods of 2 to 4 days, and they still advise activity limitation. Waddell et al. They had mentioned activity limitation, shorter periods of bed rest as well as activity limitations. More recently, even short periods of rest have come under questions. Bed rest do not improve symptoms any more effectively and other treatments than the other treatments, but does produce a number of adverse effects, including joint stiffness, muscle wasting, loss of bone mineral density, pressure sores, and venous thromboembolism. This is the Greg McIntosh et al. So all these research topics or research topics I mentioned in the reference session in the last slides. So earlier it was mentioned. So in this bed rest for this low back pain article, earlier studies has mentioned that they need longer periods of bed rest, and in the recent articles they had mentioned that recent studies found that these shorter periods are enough, as well as again they had reduced the shorter periods from 2 to 4 days to less than that, because if you're taking bed rest means it may lead to other issues or other adverse effects, including a joint stiffness, muscle wasting, loss of bone mineral density, pressure sores, and venous thromboembolism. So this is the second paradigm shift. And third paradigm shift includes early mobilization in intensive care setting. Attempts at full active mobilization are often reserved until after the acute phase of illness has resolved. So early or active mobilization in the older researchers, they had older studies, they had mentioned that after the acute condition or acute phase has been resolved only, you can able to actively mobilize the patient. So this is the older concept. In particular, it is recognized that the rehabilitation may not start until the ICU discharge, and the patients are viewed as too sick to participate while receiving the mechanical ventilations. These traditional practices are not based on high quality evidence and are simply derived from the expert opinion. So in this, Carroll et al. They had mentioned that all these traditional practices doesn't have any particular evidence, and they are mainly derived from the expert opinion. That doesn't means they have a sound methodological support. And in the shift done by in a shift, that is article done by your Joseph Adler and Daniel Malone in 2012, they had conducted a systematic review on the effectiveness of early mobilization and concluded the literature supports early mobilization and physical therapy as a safe and effective intervention that can have a significant effect on functional outcomes such as muscle strength, functional mobility, quality of life, and patient symptoms. So in the older studies, they had mentioned that active mobilization are not indicated once the patient has been discharged from the ICU. So acute phase, it has been full active mobilization have been contraindicated or not given. So in the later studies in paradigm shift, as a paradigm shift, they had mentioned in 2012 study that is by Joseph Adler and Daniel Malone. They support that the early mobilization and physical therapy is a safe and effective interventions, and that may lead to a significant impact on the functional outcomes such as muscle strength, functional mobility, quality of life, and patient symptoms. So these are about the three different paradigm shift examples which I had given in this video. So coming to the barriers in evidence-based practice, the barriers include lack of value for research and practice, difficulty in bringing the change, lack of administrative support, lack of knowledge mentors, lack of time for research, lack of knowledge about research, research reports not easily available, complexity of research reports, lack of knowledge about evidence-based practice, lack of remuneration, lack of interest, lack of involvement. So coming to the advantages of evidence-based practice, it provides better information to the practitioners or physios. It provides better patient outcomes. Evidence-based practice increases the efficiency of the physios. It keeps physiotherapy practice current to the new trends and updated guidelines of care. It promotes high quality and cost effective interventions and treatment. It enables the consistency of care. It provides the client focused care. It is a structured process, and it increases confidence in decision making that is backed by research. It generalizes the information. It contributes to the science of physiotherapy. It provides the guidelines for further research. It helps physios to provide high quality patient care. And what are the different disadvantages for evidence-based practice includes not enough evidence for evidence-based practice in particular in some particular topics or areas. It is time consuming. It reduces the client choice. It reduces the professional judgment or autonomy. It suppresses the creativity. It influences the legal proceedings. It has some publication bias. So coming to the research part of the evidence-based practice. So this was one of the older model or earlier model which was put forward by the Sackett et al. This was a three-legged stool model. So in few studies they had mentioned that this has been put forward by Sackett et al. In 1996 in the BMJ British Medical Journal. But a few studies says that Sackett didn't mention this neither mention this as a three-leg model. So this three-leg model includes here best scientific evidences and clinical experience and the patient preferences. So this was one of the oldest model or oldest outdated model of evidence-based practice. So later in the research, as a paradigm shift, they had mentioned that few of the researchers has mentioned that this three-stepped or three-leg stooled model of evidence-based practice has been rejected, and they has been modified into another model. So that is your funnel model. So this has been uh, put forward by the Eric Meira, who is a physical therapist. So this is the latest model that is known as funnel model. So funnel model for your evidence-based practice. So this Eric Meira has coined the ideas and flows beautifully. So in this, we start off considering the evidence in totality and research experiences, basic sciences, etc. Then appreciate the scientific method of disproving the factors to then lead to a clinician expertise, and finally consider the patient preferences from what is remaining. So this is the current evidence, then comes to clinical expertise, patient preferences, and finally will lead to a successful outcome. So evidence-based practice isn't a set thing, it is a constantly updating and changing as well. So that is why it is so valuable and different than the standard practice and traditions. So this is the research about the evidence-based practice. So earlier it was a three-leg stool model. Later it has been rejected, and finally this comes. And thanks for Adam Meekins for this wonderful post. So this I took from the Adam Meekins. So this is the same. So best available is the funnel model. That is the best available evidence or totality of evidence. So that includes your individual papers or systematic reviews. Next comes your clinical expertise or synthesis of evidence. That is a consensus statements and critical thinking. And next comes your patient values or circumstances. That is the honest, informed consent. So this is the latest model. That is the funnel model for your evidence-based practice, which was put forward by your Eric Meyer. So coming to the conclusion, so evidence-based physiotherapy care is a lifelong approach to clinical decision making and excellence in practice. Evidence-based physiotherapy care is informed by research findings, clinical expertise, and patient values, and its use can improve the patient's outcomes. Use of research evidence in clinical practice is an expected standard of practice for physios and healthcare organizations. Numerous barriers exist that create a gap between new knowledge and implementation of knowledge to improve the patient care. Using the levels of evidence, physios can determine the strength of research studies, assess the findings, and evaluate the evidence for potential implementation into best practice. So this is the book which I read. So this was the author name is Tammy Hoffman. So this is the book name is Evidence-Based Practice Across the Health Professions. And these are the different references which I had gone through. So please do read these articles for a better understanding, for more knowledge. So by this, I'm concluding this evidence-based practice topic, and I need to mention something which is important for every physios, that if you're updated or if you're updated today, then there is no issue. If you are not updated today, you will be outdated tomorrow. So this is what I need to tell to all the physios. If you are not updated today, you will be outdated tomorrow. So by this, I am concluding this evidence-based practice video. Thank you for watching this video. Please do subscribe and share this to your physio friends and fraternity. Thank you.